Hi, everyone. My name is Sam Stead, and I'm a postdoctoral fellow at the University of Manitoba. This year, I completed my PhD at the University of Toronto in the Department of Anthropology, and so I'm happy to be back guest lecturing so soon. During my degree, I studied reproduction and stress physiology in three species of mammal, Angolan colobus monkeys in Uganda, as well as northern and southern flying squirrels in Ontario. For part of my work, I was assessing cortisol levels in all three species. This October, I started a position at the University of Manitoba working on a project looking at the impact of stress throughout pregnancy as well as lactation on milk composition and infant weight outcomes. For part of my research, I'll be measuring cortisol in milk. Cortisol is a steroid hormone. Broadly, it's involved in energy management, and many of you may know that in stressful conditions, it's secreted in high amounts. And so today I'm not going to be talking about my own research on cortisol, but I will be discussing other steroid hormones, specifically those known to have important roles in determining sex characteristics. So for today, I'll start out with an overview of the endocrine system, specifically looking at steroid hormones. From then, I'm going to discuss what we know about the role of hormones in sexual development, both in utero and during puberty. And then after that, I'll be discussing what it means to be intersex and then reviewing some of the intersex conditions. After that, I'll be shifting to the world of sports. I've chosen to focus on sports because I think they provide a really powerful example of how, as a society, we understand sex, gender, and inclusion. Though sex is scientifically proven to be non-binary, something which I'll show repeatedly throughout this lecture, the world of sports unfortunately is. And it's within this world that biological differences are often regulated and policed in ways that really expose the limits of our understanding of sex, as well as our limited understanding of hormones and their effects on behavior and performance. In this part of the lecture, I'll specifically be discussing world athletics policies over the years on who's eligible to compete in the women's category. Before delving into the endocrine system, which will be the first part of my lecture, I want to quickly review an important question that I know you've discussed already in this course. So what is sex? In high school, most people learn that humans have 46 chromosomes and that anyone with two X chromosomes is a female, will have a vagina, and will have low testosterone levels. On the flip side, they learn anyone with an X and a Y chromosome as male, will have a penis, and will have high testosterone levels. However, this is very oversimplified and not entirely true, uh, much with most of what we learn in high school. So for example, someone with two X chromosomes can have a penis and testicles, and then someone with X and Y chromosomes can have a vagina. As well, some people with two X chromosomes can have very high levels of testosterone. In fact, medical experts often discourage the use of the terms biological male or female, as there's really not one thing that makes someone a male or a female. So really the takeaway from this slide and what you've discussed in this course already is that sex is not a binary. And so this is something I hope you'll be convinced of, if not already, but by the end of the lecture. Okay, so the endocrine system. The endocrine system is a network of glands and organs that produce and release hormones into the bloodstream. Hormones, in turn, are chemical messengers that carry these messages from one tissue to another. So they control and coordinate virtually every function in the human body, from metabolism and growth to reproduction, immune functioning, and even mood. So just as one example, many of you are probably familiar with insulin. This is a hormone secreted from our pancreas, which you can see here. It travels again throughout the bloodstream to tissues throughout the body. And it's within these tissues that it signals to cells that they should allow glucose to enter so that it can then fuel various cellular processes. So these are all the glands and organs that make up the endocrine system. I'm going to be focusing on these four here. So specifically because they are the organs that secrete steroid hormones. So we have adrenal glands, which are just on top of our kidneys. So we have two of those. People also have two ovaries and two testicles. And then the placenta is present only during pregnancy, but it also secretes steroid hormones that are important for fetal development. And so again, the reason I'm focusing on steroid hormones is that they have many important roles in the development of sex characteristics. I also wanted to quickly mention the hypothalamus and the pituitary gland. So these structures don't secrete steroid hormones themselves, but they do secrete other types of hormones that are required to trigger the secretion of steroid hormones down in these organs here. So I'll discuss these more later on, but I just wanted to mention them now so you can get a sense of where they're located in the body. So this slide shows a breakdown of the steps involved in steroid hormone synthesis. So this synthesis is what would take place in the adrenal glands, ovary, testes, or placenta prior to the hormone being secreted into the bloodstream. So you can see at the top left here that the starting product for all of these steroid hormones is cholesterol. So we often think of cholesterol as something that's bad for us, clogs our arteries, and causes heart disease. However, in moderate levels, it is important for different functions, and so this would be one of them. You can see that all of the steroid hormones that are synthesized from cholesterol, so all of them here, they have that same four-ring structure as cholesterol, which is helpful when we want to actually measure the level of these hormones in the blood. So there are 5 classes of steroid hormones, and these have all been determined based on the action of the hormone. So glucocorticoid is the first one I'll talk about. And so the most common glucocorticoid in our body is cortisol, which I've mentioned already. And so, like I said, glucocorticoids are largely responsible for energy management. So this is why when we encounter a stressor, cortisol will rise rapidly in our blood and is what is actually going to divert energy towards whatever function we need to respond to that stressor. Second, mineral corticoids. So these we hear a little bit less about, but they're in short responsible for salt and water balance in our body. And then lastly, androgens, progestins, and estrogens. So these are, each of them are their own class, but together they make up the sex hormones. And so androgens are, an example of an androgen would be testosterone is the most common one in humans. And so you can see that right down here. And I should have mentioned earlier cortisol. You can see here and aldosterone here, which is a mineralocorticoid. So testosterone is the most common androgen in humans. Uh, Estradiol, which is actually made from testosterone, that would be the most common estrogen in human bodies. And then lastly, progestin. So the most common one that we have is progesterone, which you can see is pretty early on in the synthesis pathway, just 2 steps from cholesterol. So anyways, I'm going to be discussing the functions of each sex hormone in more detail later, but I just wanted to show you this synthesis pathway and go over the 5 classes of steroid hormones. And then now I want to discuss some basics of how they actually function in the blood and cells, as this is important for understanding what's going on in the body when we measure hormone levels. So because cholesterol is a fat and the basis of steroid hormones, that means that these hormones are fat-based, and so they're actually hydrophobic, meaning that they don't mix well with water. Because of that, these hormones need carrier proteins to be able to move through the bloodstream because blood is water-based. And so uh, once these steroid hormones being carried by their proteins actually reach the target cells, they have to be released from the proteins because when they're bound, they're not able to pass into cells. However, once they're released, they can pass freely through the cells because the membrane is fat-based. So they'll be released from the proteins, travel into the cells, And then within these cells, they'll actually bind to receptors, which you can see here are labeled with Rs. And so once the steroid hormones bind to their receptors, together, this complex, they'll move into to reach the DNA. And so once they reach DNA, they can then activate transcription to produce protein needed for the required response. And so, given all of this, we know that the action of steroid hormones in a cell depends on a variety of things. So, one being the concentration of unbound hormone in the blood, because as I mentioned, hormones that are bound to their protein carriers are unable to pass into the cell. Second is the number of receptors in the cell, because like I said, if the hormones reach the cell, they're inside, but there are no receptors, they're not going to be able to exert their effect. And then three would be the availability of co-activators for gene transcription. And so these are required to actually produce proteins, which again is the ultimate driver of hormone action. So all said, what this means basically is that we can't simply measure the concentration of a steroid hormone in the blood and assume that higher levels means that this hormone is having more of an effect. We have to really consider what's happening at the cell level, which makes it a very complicated picture and an area of research that still has a lot of ongoing work. Next, I want to talk about feedback loops, and this will actually be the last part of the endocrine system of the lecture. So feedback loops are important features of the endocrine system because they ensure that the body maintains an appropriate level of hormones in the bloodstream. So essentially what we have is hormones that are able to then regulate their own secretion through either positive or negative feedback. And so I'll explain this more with some examples. So this is an example of a negative feedback. And so it comes from the menstrual cycle. As I mentioned earlier, the hypothalamus and pituitary gland in the brain are important for regulating the secretion of steroid hormones. So here you can see that to initiate the secretion of estrogen and progestin, the hypothalamus in the brain must first release gonadotropin-releasing hormone, or GnRH, which will then travel to the anterior pituitary, which will then be told to release FSH, or follicle-stimulating hormone, and LH, luteinizing hormone, which then travel through the bloodstream to the ovaries. There, they signal to the ovaries to release estrogen and progestin. And so for most of the cycle, most of the menstrual cycle, what we see is that high levels of estrogen and progesterone or progestins actually feed back and exert negative feedback on the hypothalamus and the anterior pituitary. So they actually cause a decrease in GnRH, FSH, and LH, which then subsequently causes a decrease in estrogens and progestins. So it's a negative feedback loop. This is the case for most of the menstrual cycle, like I said. However, around ovulation, which is the time when the ovaries actually release an egg into the uterine tube to potentially be fertilized by sperm. So around this time, something switches, and what we see is that estrogen actually has a positive effect. And so it causes the hypothalamus and the anterior pituitary to release more GnRH, FSH, and LH, which again causes a greater release of estrogen, feeding back, and again having a positive feedback. So this leads to a surge in estrogen, which is what is required for ovulation to occur. So understanding these feedback loops is going to be important later on when I explain one of the intersex conditions. And just generally, it's a really important part of how the endocrine system is able to regulate hormone levels internally. So with that, I'm going to shift to our next topic, which is sexual differentiation and the role of hormones in these processes. So first, I want to discuss prenatal sexual differentiation. So this is what happens in the womb. So early on after conception, all fetuses have the same physical appearance. And so you can see that here. The yellow is a gonad, so this can either become a testes or an ovary. And then the Mullerian duct and the Wolffian duct are both present. So basically what happens next is this fetus can go on one of two pathways, and it's really going to depend on whether or not it has an SRY gene, which is on the Y chromosome. So if there is a Y chromosome present with an SRY gene, uh, it'll start heading down this first pathway that I'm going to describe. And so I'll say the SRY gene is short for the sex determining region of the Y chromosome. And so this gene encodes a protein known as a transcription factor, which activates other genes that lead to the eventual development of testes. And so the testes are then responsible for secreting two hormones, anti-Mullerian hormone, which causes regression of the Mullerian duct, which you can see here, and then testosterone. And testosterone triggers the development of the Wolffian duct, which actually becomes the seminal vesicles and other internal structures that connect the testes to the prostate. Testosterone can also be converted into another steroid hormone, another androgen called DHT, which has a stronger effect than testosterone and actually triggers development of the penis. So the genital tubercle will grow into the penis. On the other hand, a fetus without a Y chromosome will not develop testes and so will not receive any AMH. And so in the absence of anti-Mullerian hormone or AMH, we will see development of this Mullerian duct. And so it will actually become the uterine tubes, the uterus, and the upper portion of the vagina. Again, in the absence of the SRY gene, this gonad will become an ovary. And then in the absence of testosterone, we'll actually see that the genital tubercle is going to experience less growth and it'll end up as the clitoris. So in summary, it's really the action of this SRY gene on the Y chromosome that initiates this development into the first pathway that I described. But there are many steps involved and many hormones that are required to reach this typical male development. So this table presents the same information again, just to make sure that everyone followed. So we can see that these three hormones on the left are important in that first pathway. Testosterone and dihydrotestosterone are both steroid hormones, specifically androgens. And then anti-Mullerian hormone, it's not a steroid hormone. It's actually a peptide hormone, but I've included it here as it's important in this in utero sexual development. Okay, so the second stage of development that I want to discuss is puberty. In people with testes, testosterone secretion will start to increase a lot around puberty, and this will lead to the development of different secondary sex characteristics. This is also a time when trans people may choose to start taking testosterone if they're able to and if they're legally allowed to, so that their body aligns with their gender identity. You discussed gender identity in an earlier lecture, so I'm not going to spend more time on it here, but I will be talking later on about trans inclusion in sports. So testosterone leads to a variety of secondary sex characteristics. So we see increased body hair, greater muscle size and strength, greater bone size and strength, as well as an increased sex drive. It'll cause the vocal cords to lengthen, which causes voice deepening, as well as promotion of red blood cell production. So this leads to higher levels of circulating hemoglobin. For those that have testes, testosterone is also going to stimulate sperm cell production. In people with ovaries, estradiol and progesterone start to increase around puberty. So this is a time again when trans people may start taking estradiol so that their body aligns with their gender identity. Estradiol stimulates body hair growth, widening of the hips, as well as development of breasts. In people with ovaries and uterus, estradiol also regulates the menstrual cycle, I discussed earlier its role in, for example, ovulation, but it also has a role in thickening the uterus lining, promoting egg transport through the uterine tube after ovulation, as well as uterus contractions, either during menstruation or during birth. Progesterone is also important to the menstrual cycle, particularly in maintaining the uterus lining during pregnancy. Now that I've gone over the roles of hormones during in utero and pubertal sexual development, I'm going to next discuss some intersex conditions. Intersex is an umbrella term used to describe people with variations in sex characteristics, such as chromosomes, anatomy, or hormones, that don't fit typical male or female bodies. So these conditions often result from variation in early life development. And so as a result, intersex people are often referred to as people with differences in sexual development, or DSD. And you'll hear this term later on when I discuss World Athletics policies. There are many intersex conditions, some of which you've covered in this class already, such as Klinefelter and Turner syndrome, but I'm going to be specifically focusing on the conditions that are of most interest in the sporting world, which tend to be those of people with XY chromosomes that are identified as, or that are identified at birth or self-identify as female. The first condition that I'll discuss is congenital adrenal hyperplasia, or CAH. And so this can occur in people with either XX or XY chromosomes. It's one of the most common intersex conditions in the world and has a prevalence of 1 in 15,000 people. People with CAH have a deficiency in an enzyme required to make glucocorticoids and mineralocorticoids. Deficiency of 21 hydroxylase is the most commonly defective enzyme, which leads to CAH, being the case in more than 90% of people with CAH. So here you can see that in the synthesis of cortisol, which we have on the right, what you need is 17-hydroxyprogesterone to be converted into 11-deoxycortisol, and from that, it's converted into cortisol. So in that first step, 21-hydroxylase is the enzyme that actually facilitates this conversion of 17-hydroxyprogesterone to 11-deoxycortisol. However, if this enzyme is deficient, that first step can't occur, and ultimately cortisol can't be made. And so this is, again, the most common deficiency in people with CAH. So now we have to think back to the negative feedback loops that I've discussed earlier. So what happens is the brain senses that cortisol levels in the blood are too low. And so it signals to the adrenal glands through increases in these hormones that I mentioned earlier. It signals to the adrenal gland to actually work harder and then try and produce more cortisol. And so as a result of working harder, the adrenal glands actually grow in size, which is what hyperplasia means. However, although these adrenal glands are working more, there still is no 21-hydroxylase enzyme. And so this leads to an accumulation of precursor hormones, which in this case would be 17-hydroxyprogesterone. And so if you look back at the slide I showed earlier on at the synthesis pathway, several of the precursors for glucocorticoids and mineralocorticoids are actually the same as the precursors for sex steroid hormones. So here, this is the pathway I showed earlier, cortisol being over here. And so this enzyme, if it's deficient, like I said, you're going to have an increase in this precursor here. And so if it can't be converted into 11-deoxycortisol, it will instead be converted to androstenedione, which can be converted to testosterone and one step further to estradiol. And so the symptoms of CAH can range from mild to severe, depending on the specific enzyme missing to make glucocorticoids or mineralocorticoids. And so in individuals with two X chromosomes who have CAH, testosterone levels can be very high, causing virilization and resulting in atypical genitalia, such as an enlarged clitoris. Some infants are actually pronounced male at birth, though most are still pronounced as female. And then in terms of gender identity, about 95% of people with this condition identify as female. However, they will often have elevated levels of testosterone. The second condition that I'm going to discuss is androgen insensitivity syndrome, or AIS. So this syndrome occurs when people with XY chromosomes have a mutation that prevents them from making a protein called an androgen receptor. And so thinking back to this diagram of how steroid hormones act on cells, one of the most important determining factors was the number of receptors in the cell. So the number of these red R structures here. If cells don't have these functional receptors, they won't be able to detect testosterone and then bind to it and then ultimately have this effect on gene regulation, which is what the ultimate action of testosterone would be in the cell. And so in terms of the expression of AIS, there are two sort of subdivisions. Those with complete androgen insensitivity, so their bodies are unable to respond to testosterone at all, and then those with partial androgen insensitivity. And so this can really vary depending on that person's specific biology. This division into complete and partial is used by some, but in reality, this occurs along a continuum. But we'll see a bit later on why this division into partial and complete is important in sporting policies. Children with complete androgen insensitivity syndrome do not develop typical male external genitalia, so they don't develop a typical penis, as their bodies aren't responding to the testosterone produced during in utero development. As a result, they're often assigned female at birth. And more often than not, they don't have any idea that they're different from other girls until they reach puberty and don't menstruate. Individuals with complete AIS almost universally identify as female. On the other hand, people with partial androgen insensitivity syndrome have varying anatomy, and it seems the gender identity varies as well, depending on a variety of factors. Lastly, I wanted to discuss 5-alpha reductase deficiency. And so this condition occurs only in people with XY chromosomes. So in the development of the penis and the scrotum, which I mentioned earlier, I talked about how testosterone is converted to dihydrotestosterone, and that this DHT is what actually causes the genital tubercle to lengthen into the penis. And so this conversion of testosterone to DHT is facilitated by 5-alpha reductase 2. However, in people with a deficiency in this enzyme, they're unable to convert T to DHT, which leads to a decrease in the production and then ultimately genital ambiguity. Similar to the previous condition that I mentioned, many individuals are believed to be female at birth and are consequently raised as girls. However, at puberty, again, there can be significant virilization. So this is different than the last condition, but what actually happens is the increase in testosterone levels actually causes these individuals to, some of them at least, to grow a penis, and some start to develop secondary sex characteristics. And so at this point, many realize they're different than other girls, and they may occasionally change their gender identity. 5-alpha reductase is a rare condition. It's not known how common it is, but there are large families with affected members in the Dominican Republic, Papua New Guinea, Turkey, and Egypt. Interestingly, in some of these countries, communities have words for those with 5-alpha reductase deficiency, such as huevodoses in the Dominican Republic, which translates to penis at 12. So I wanted to take a moment here to briefly mention ongoing advocacy work surrounding intersex bodily autonomy. So as you just learned, many intersex infants are born with ambiguous genitalia, and these infants are often subjected to medical interventions aimed at normalizing their bodies. So many advocates in response to this are working to challenge these practices, instead centering the rights of intersex people to make their own decisions about their own bodies when they're able to. So these advocates really emphasize that non-consensual surgeries can have lasting physical and psychological effects, particularly if they decide that their gender identity at birth, or their gender identity rather, doesn't align with the genital surgery that they were given at birth. So for the last part of this lecture, I'm going to be shifting to the world of sports to show really how misconceptions of biological sex have led to the exclusion of many women from competition. Specifically, I'll be focusing on the history of sex testing done by World Athletics to determine who's eligible for the female category. And so for folks who are unfamiliar with World Athletics, this is the international governing body for track and field and cross-country running. So they would be the organization that decides who's eligible for competing in the Olympics female category. This organization has used anatomical, chromosomal, and more recently hormonal markers of sex to determine who's eligible, which, given what we've learned, is a problematic and scientifically unsound way to determine who is a woman. So first, I want to just situate women's sports, as it was only in the 1900 Olympic Games in Paris that women were first able to participate. And even then, they were limited to sports that were considered suitable for women, which at this time and place was tennis and golf. It wasn't until 1928 that women were first allowed to compete in track and field. So that year, in 1928, the 800-meter race in particular spurred a lot of controversy. The sight of some women falling to the track after the race was taken as a sign that this was too strenuous for women. And you can really see this here in this article, where the title is Collapse of Women at the Olympic Sports, Doctors Condemn Their Participation. Of course, in reality, it's common to see people, both male and female distance runners, sprawled out after a race. However, Olympic officials didn't accept this as normal, and women were not allowed to run the 800-meter race again until the 1960s. Even once women were allowed to compete, there were several restrictions put in place to ensure that only certain women would qualify. So I'm going to start out with the 1940s up to the 1960s. So during this time, all athletes who wished to compete in the female category were required by World Athletics to provide what they called a certificate of femininity. And so this involved an examination by physicians of the athlete's external genitalia. In some competitions, such as the European Athletics Championships, authorities required females to present themselves in what was called a nude parade before a panel of gynecologists. So really, women would line up single file parade past these gynecologists, who were then able to decide whether or not the person in front of them was considered a woman. Many describe this as degrading, invasive, and unsettling. In 1948, a scientist at Western University in Ontario named Murray Barr discovered that the cells of female cats looked different from the cells of male cats. The nucleus of female cats looked darker because of that second X chromosome. And so this dark stain became known as the Barr body, named after the scientist who discovered it. And so in 1967, this Barr body was actually used to determine whether an athlete was male or female. Many scientists, including Dr. Barr himself, pushed back against the use of the Barr body, recognizing that this is only a minor detail in the femaleness or maleness of a whole person. Despite this pushback, the Barr body test was used by World Athletics until the 1980s to determine who could compete in the female category. In 1985, Spanish hurdler Maria Jose Martinez Patino received the results of her Barr test and was informed that, to her surprise, she had an X and a Y chromosome. As a result, she was classified as male and declared ineligible for the women's category. This came as a shock to the athlete, who it turned out had complete androgen insensitivity syndrome. Maria fought for reinstatement and 2 years later won this fight. So she was able to compete in the end. And after that, in 1988, 3 years later, World Athletics actually dropped the Barr body test, conceding to the advice of scientists and medical experts that these two chromosomes were not enough to determine or not what should be used to determine if a competitor was a woman. In the 1990s, World Athletics stopped mandatory testing of all women and shifted to suspicion-based testing during health checks. And so this was done for all athletes during that sort of preliminary health check before a race. And it really meant observing female athletes and deciding based on their appearance whether they exhibited manly traits and should be inspected further. These suspicion-based checks were the norm until 2011, when World Athletics shifted its focus to hormones, specifically testosterone. In 2011, they instituted a rule whereby an athlete assigned female at birth and with a legal female sex designation may compete if her testosterone levels were below 10 nanomoles per liter for 6 months. As well, she had to if the levels were higher and she had androgen insensitivity, they would then test her to determine whether it was complete or partial. And if it was complete androgen insensitivity, she would be allowed to compete. So I'll note here that there is no universally accepted or standardized means of assessing androgen insensitivity. Instead, the assessments by World Athletics were based on material androgenizing effects, such as clitoral size. So you could have two athletes with partial androgen insensitivity syndrome that were treated differently based on their clitoral size. So in 2011, female athletes with testosterone levels above 10 nanomoles per liter and no androgen insensitivity had two choices. They could either withdraw from the race, or they could lower their testosterone levels through medication or by surgically removing their internal testes. So I wanted to show this clip of a runner from Uganda called Annette Nagesa. And so she specialized in the 800-meter race. She was the gold medalist in the 2011 All-African Games and won bronze at the 2010 World Athletics Cross-Country Championships. Annette was notified that she had testosterone levels above the 2011 limits, and so she was told that she had to reduce her testosterone levels to be able to compete. Facing pressures from authorities and wanting to continue her career in running, she underwent a gonadectomy, which she says was not clearly explained to her at the time. The lack of care following her surgery and the harm to her physical and mental health effectively ended her career. And so I want to show this clip to give a bit of space to her story.
Prayer of my past world championship. I was very, very happy to go on with the sport and going to another level. Preparing for London Olympics, me plus my coach, we were working very hard so that our dreams comes true. Yeah. Because our dream was to reach the finals. As long as we reach to the finals, yeah, anything can happen there. Some few weeks to the departure to the London Olympics, that's the time when I received a call from my international manager telling me my blood sample, they're having some problem, technical problem, and you can't go for the competition. My local officials from my federation told me that you have to stay home, no moving. Yeah. And if anyone asks you, tell them that you have an injury whereby I was a person who is injury free. I was very normal, I wasn't sick. One official from the IWA, he tried to reach me, and after some few weeks, I think, they had me travel to go to Nice for body checkup, like measuring my whole body and putting me to machine, yeah, just like scanning me, the whole body, and getting more other blood samples from me. It was something which was really confused, like as if there are people who are not talking straight to you, telling you that this and this like this, yeah. But just telling you do this, do this, do this, yeah. Went to a doctor with an executive from the federation because she was with me, escorting me, going to the hospital. They took me to the operation room, and they say that they are gonna use the injection thing. By waking up, finding myself, I'm having cuts. I say, whoa, they've done something which we didn't agree on. Yeah. And really, I was so scared. The people who were there with me, taking me to the hospital, who wanted me to do side. After the operation, no one came back to me to see what no one came in to do a follow-up. No one explained to me what's really the truth. So something which was just making me to go in that trap. I call it trap because it was a trap. Yeah. Took me 7 years without nothing. As in, they didn't give me straight information that after the surgery you have to go for chemotherapy throughout the whole of your life. Yeah. Really, that was so hard on me. For 7 years, no one is coming to look for you. For 7 years, no one is minding to know where you are. Yeah. So really, a strange life.
As soon as you pass it, you start slowing down the pace. Don't sort of focus on the stride length. Keep the body moving. You know what I mean? That you feel that the body is moving at the same pace. Yeah.
Why are they focusing too much? People of the southern continent. Yeah, that shows that you're discriminating and racism in the sport because all of us, we are human beings and we are failures. Yeah. What I can say, let them stop taking people's or playing on people's bodies. Yeah, making people to be guinea pigs and doing their research on human beings and violating human rights. Yeah. My dream at first was taken away from me, but with God, I trust that it will come back to me. And now I came back for training and I'm already in the process. I'm working for it again. I have to fight for my dream. I have to fight for it. That's my future now. I'm focusing on my dream, which was taken away from the IWF regulations.
Okay. So just for folks who are unaware, the IWAF was the previous name of World Athletics. So that's who Annette is referring to at the end there. And so I just want to also reiterate the power dynamic in elite international sports that Annette discussed. So this is where we have governing bodies based in the global north that hold authority over critical issues such as inclusion in sports. And so this is frequently to the detriment of athletes from the global south. And so this is a pattern that's going to continue to emerge throughout this lecture, but I wanted to just highlight it here following Annette's video. So in 2011, as well as this regulation for DSD athletes, World Athletics also introduced its first policy for transgender athletes. So they decided that athletes who underwent sex reassignment surgery could compete in their affirmed gender if they, one, had completed their surgical anatomical changes. So they'd had both internal and external surgery. They'd had legal recognition of their gender. And then third, they'd undergone hormone therapy for at least 2 years. The levels of hormones were not specified for transgender athletes. These regulations were in place until 2015, at which point they were actually forced to suspend regulations following an appeal from an athlete named Dutee Chand. And so Dutee was an Indian or is an Indian Olympic sprinter with high levels of testosterone, who was told by World Athletics that in order to compete, she had to lower her testosterone levels either through surgery or medication. Chand argued that the high testosterone levels in her body were natural and that medical experts had actually advised her that the interventions suggested by World Athletics were unscientific, invasive, and could actually harm her health. She took this to the Court of Arbitration for Sport, which is an international body that was established to settle disputes related to sport. And so at this trial, the Court for Arbitration of Sport ruled that there was insufficient evidence to support these eligibility rules, to support that athletes be required to reduce their testosterone levels to below 10 nanomoles per liter. And so the court said that World Athletics had 2 years to then gather enough supporting evidence to actually support these rules. So this was, of course, big news, as it meant that DSD athletes or intersex women who had been taking testosterone suppressing medication could now get off it. Obviously, I'll just say that those who had opted for surgery to lower their testosterone levels, either voluntarily or in a coerced way, as you just saw, could obviously not reverse that decision. So from 2015 to 2019, there was no official World Athletics sex testing regulations in place. In 2019, World Athletics implemented new rules that differed from the 2011 ones in several ways. In terms of DSD athletes, they only applied to a subset of races. Second, they set a lower testosterone limit. So instead of being 10 nanomoles per liter, they cut this in half to 5 nanomoles per liter. And then third, they only focused on women with a subset of intersex variations characterized by natural testosterone levels. In terms of transgender athletes, there were also changes made to these regulations in 2019. So now the rules were that any transgender woman who wanted to compete must now have less than 5 nanomoles per liter of testosterone, so the same as for DSD athletes. But now instead of having the levels monitored for 2 years, it would only be for one year or 12 months. And then finally, no surgery was required for transgender athletes to compete. Following the announcement of these new regulations, an athlete named Caster Semenya filed an appeal. Caster Semenya is a South African Olympic gold medalist who has elevated testosterone. She took medication from 2010 to 2015 to lower her testosterone levels so that she could compete. However, she said that these medications caused her a variety of unwanted side effects. So she experienced fevers, nausea, and abdominal pain, as well as mental health problems following this medication, such as depression. So once World Athletics announced the reinstatement of these testosterone level limits, she refused to go back on this medication and decided to fight the new rules. In 2019, the Court of Arbitration for Sports ruled against Semenya, and then after that, she took it to the Swiss Federal Tribunal, which also ruled against her. However, in 2023, she's continued this fight, and she took it to the European Court of Human Rights, who found that Switzerland had not afforded her sufficient institutional and procedural safeguard. So while this was a win in her favor, the regulations are still in place, and she has not been allowed to race because of her testosterone levels. In 2023 as well, there were changes again to World Athletics regulations. They again lowered the threshold for blood testosterone levels, cutting it in half once more to 2.5 nanomoles per liter. Furthermore, while in 2019, the athletes were only required to reduce their blood testosterone for a continuous period of 6 months, the updated 2023 regulations required that this be maintained for a period of at least 2 years, which is a significant increase. In 2023, with regard to transgender athletes, World Athletics at that point decided to ban any women who have gone through quote unquote male puberty from competing, which effectively bans virtually all trans women from competition. Lastly, this September in 2025, World Athletics also introduced a new one-time genetic test for an SRY gene. So only those with a negative SRY test are now eligible to compete in the female category for World Athletics. So in many ways, we're back to the 1960s, where a woman is essentialized as someone defined by a specific genotype. With regard to the impact of gender-affirming hormone therapy on sport performance, I wanted to take a moment to highlight how little we really know about this. As of today, only 5 peer-reviewed studies have tracked changes in athletic performance in trans athletes before and after gender-affirming hormone therapy. Out of these studies, only 1 was prospective and longitudinal and tracked actual competition results rather than lab-based measures. This 2025 study tracked competition times of 9 runners before and after starting hormone therapy. So you can see here the age-graded scores before and after therapy for 9 athletes. And so the colors correspond to the different types of distance. So we have long distance in orange, middle distance in green, and then sprints in blue. And so the second bar would be the performance after hormone therapy. So you can see some of their scores increased after therapy and some decreased. On average, the runners were 15% slower after starting their hormone therapy. And so these would all be women, trans women who are undergoing gender-affirming hormone therapy. So this decrease in performance by about 15% is interestingly about the same difference in performance expected between cis men and women. Regardless of the results, my point here is that these rule changes made by World Athletics and these decisions of hormone levels in the blood are really based on no research, given the lack of research that's been done. So, it's important to recognize the state of the research on this, as these changes of again, the level of the hormones, as well as the amount of time that, for example, trans individuals need to be on hormone therapy, is not based in actual data. I want to show you next a clip of the panel discussion that followed the announcement of these new regulations. The person answering on the right is named Sebastian Coe, who served as the president of World Athletics for the past 10 years. So he's been central in shaping many of the organization's policies that I've discussed, including those concerning eligibility and inclusion in the women's categories. Ed.
Hi. So on the gender verification, what are the pre-clearance tests, and will they apply to every athlete trying to compete in women's athletics?
Look, the pre-clearance testing will be for athletes to be able to compete in the female category. The process is very straightforward, frankly, very clear, and it's an important one. And we need to look. We will look for a testing provider. We will work on the timelines, and the test will only need to be done once in the career life of an athlete. So we are very clear, and that was agreed today in council.
So are these swab tests?
Well, yeah, the swab test. I mean, we've had the working group and our medical teams have been looking at that. But look, that is largely the two determinants here are, firstly, finding the right provider, because we are a global sport. So you do need to provide a provider with the capacity, the scale and capacity to be able to do that. And cheek swab or the dry blood test. But yeah, it'll be it's along the lines of something that will be administered once in the career of an athlete, a female athlete.
Exactly. Why do you think it's so important to do it? And also, are the DSD parameters changing as well?
It's important to do it because it maintains everything that we've been talking about, and particularly recently, about not just talking about the integrity of female women's sport, but actually guaranteeing it. And this, we feel, is a really important way of providing confidence and maintaining that absolute focus on the integrity of competition.
I'm sorry, Barney. I just say, Barney, are you prepared for any resistance about some criticism if it's too intrusive?
No, neither of these are invasive. They are necessary, and they will be done to absolutely international medical standards.
Thanks, Rob. Jamie Gardner, PA.
Just following up on Rob's questions there on the pre-clearance testing. Is World Athletics confident that these tests and the policy that you've adopted will stand up to legal challenge? And what feedback did World Athletics get from athletes as part of the consultation on this?
Well, if I deal with the second part of your question straight away, I mean, we've had over 70 individual groups that responded from this, various stakeholders, obviously all the advocacy groups, athletics federations, athletes commissions, individual athletes, CIS, DSD, transgender coaches. I mean, this has been a widely held and pretty exhaustive review. And overwhelmingly, the view has come back that this is absolutely the way to go, within the caveats that Rob just raised and I answered just a few moments ago. Sorry, the first element of your question, remind me.
Yeah, just whether you're confident that the rules will stand up to legal challenge and scrutiny.
Well, yes, I am. But you accept the fact that that is the world we live in. I wouldn't have set off down this path in 2016, 2017 to protect the female category in sport if I'd been sort of, anything other than prepared to take, the challenge head on. We've been to the Court of Arbitration on our DSD regulations. They've been upheld, and they've again been upheld after appeal. So we will doggedly protect the female category, and we'll do whatever is necessary to do it. And we're not just talking about it.
Thank you, Seb. That does it for the questions for now.
Throughout these policy discussions, World Athletics has repeatedly invoked the principles of integrity and fairness. These are terms that carry a great deal of weight in the world of sports. The organization insists that these regulations are vital to protecting the female category and ensuring equitable competition. However, when we look beyond this rhetoric, we see how these arguments really fail to hold up in practice. These are the same regulations that have led to the systematic exclusion of numerous athletes, particularly women from the global south and those with intersex variations or trans identities. Their lived experiences reveal the human cost of policies that claim to be about fairness, but instead reinforce exclusionary definitions of womanhood.
Ed.
To bring these perspectives into the conversation, I wanted to share a few book titles written by trans and intersex athletes who've been directly impacted by these regulations. Their stories are crucial as they offer firsthand insight into how these policies shape lives, careers, and identities. Including their voices allows us to move beyond institutional narratives and confront the real personal consequences of these decisions. So to wrap up, there are 3 key points I want to leave you with. First, biological sex is not a binary. So while Western society often relies on fixed male and female categories, biology tells a much more complex story. Sex characteristics exist on a spectrum, and genetic, hormonal, and anatomical factors don't always align neatly into these two distinct groups. Second, I want you to take away that hormone levels don't provide the full story. Policies that rely on testosterone thresholds assume a direct, predictable relationship between hormones and athletic performance. However, I hope you've seen here that the evidence for this is far from clear. Reducing athletic ability to hormone levels oversimplifies the science and erases the complexity of what makes someone excel in sport. And finally, World Athletics sex test policies represent more than just a sporting issue. These regulations show how societies try to police and define bodies, deciding whose identities are legitimate and whose are not. These same assumptions that shape sex testing in sport also appear in medicine, law, and everyday life, where people who don't conform to these rigid gender norms are subjected to scrutiny and exclusion. For instance, most medical research and clinical practices still divide participants and patients into male and female categories, which erases the existence and the specific health needs of intersex, trans, and non-binary people. This binary framework produces incomplete science and inequitable care, as diagnostic criteria, drug dosages, and disease risk models are built on a narrow understanding of sex in the body. As well, there is a rather unnecessary pathologization of bodies that don't conform to this binary. For instance, the non-consensual surgeries performed on intersex infants and children that aim to normalize their anatomy rather than support their well-being. These practices reveal how medicine, like sports, often acts as an enforcer of the sex binary, shaping bodies and identities to fit societal norms and ultimately excluding certain groups of people. Thank you for listening today. If you have any questions, you can email me at this address here, sam.stead@umanitoba.ca, and I hope you enjoy the rest of the course. Thanks.